more addressing the visceral vessels. But again, today, having bespoke devices being made for each patient, essentially nearly completely doable. Again, with varying degrees of complexity. And certainly, nowadays, I think that in dedicated centers such as you would get in Heidelberg or in Paris or in London, you could nearly do anything. The problem, though, is that these devices are expensive. Devices nowadays are in the region of between $40,000 and $50,000. And they can, this can become quite a difficult and expensive environment. Certainly in South Africa, we have a number of programs that have started using these in the private sector, as well as in our teaching hospitals. But because of the costs, they are, we still have limited opportunities. Dealing in the arch of the aorta and in the ascending aorta, I must say to you cardiac and thoracic surgeons, that area is, as much as they, people have started working in the aortic valve environment, those are areas that are now starting to become very interesting as well. And I've certainly been in meetings where we have seen data from really quite substantial centers with reasonable outcomes in the ascending aorta as well. So I think we're going to be, this is an area that is going to get more and more popular and more accessible to us with newer devices. The one thing, though, that's becoming clearer, though, which is something that I think is true for all of surgery, is that specialization and expertise is going to have to be concentrated. I would not want to see South Africa having more than 2 or 3 centers of excellence looking at using complex aneurysm repairs, and certainly it would be true for the work in the ascending aorta as well.
Thank you. But at the lamb level, what is your option now? Will you be comfortable to have the option of endovascular, or you still be at your choice to be still be the open repair instead of endovascular? What is your option?
Well, Herbie, as I mentioned, I think that vascular surgery has become an endovascular specialty, and certainly in South Africa, as a guest, I would think that 75% of the work that a vascular surgeon does nowadays is endovascular. We already are in a situation where we're concerned that some of our trainees do not have enough experience with open surgery, and we are needing to think about a way that they can be trained appropriately in this line. For example, today, a ruptured abdominal aortic aneurysm, which was the area in which, when I was training, we really learned our true skills, is something that the vast majority of our trainees just do not get the exposure and the number for them to be really comfortable and expert at it. In terms of bypass surgery in the lower limb, there's still a need for it, and we are able to achieve that. But very much like in many other parts of the world, in fact, most of our trainees really are training in vascular access for dialysis access as their area where they're learning most in the open techniques.
Thank you so much. Yes.
Thank you, Professor Weber. My question is concerning the peripheral artery disease screening. I want to know what is the place of the automatic device for measuring the ABI? What's the place of the automatic device?
So at this stage, very few large screening studies have been done using a automated blood pressure device. But the evidence is that if the leg or the arteries in the leg are compressible, that in fact, using a standard platysmograph, that one can do an ABI in that manner. But I haven't as yet seen a substantial study looking at it from a screening perspective. Certainly in the direct diagnostic perspective, that is certainly something that's worth doing. Have I answered your question?
Okay, thank you so much. So now we will shift for the second presentation. Thank you so much for your beautiful presentation.
Thank you very much, Avi. Goodbye.
Okay. So the second presentation will be given by Professor Ododom. May we have the shot, the photo, and the shot be bio. Le professeur François Ododom est professeur titulaire de chirurgie thoracique et vasculaire. Il est le chef de département de chirurgie à la faculté de médecine de Libreville. Il est le président du comité pédagogique de la faculté de médecine de Libreville et le chef du département de chirurgie du centre hospitalier universitaire de Libreville, le président de la Société gabonaise de chirurgie. Il est actuellement le vice-président de l'Association africaine des chirurgiens thoraciques et cardiovasculaires. Il est un des pionniers de cette association. Il a été secrétaire général de la Société de chirurgie d'Afrique centrale et le rédacteur en chef des annales africaines de chirurgie thoracique et cardiovasculaire. C'est un réel plaisir pour moi de donner la parole au professeur François Ododom pour son intervention sur la chirurgie vasculaire en Afrique.
Okay, I'm going to give my lecture in French. So when you are ready, you can start.
Can you have the slides? The slides, please. Okay.
Okay, thank you. Alors, nous allons parler de la chirurgie hybride. En fait, mon propos, ça va être quelles sont les nouvelles avancées de la chirurgie vasculaire. Ce que je me suis proposé de faire, c'est de faire un peu l'historique de la chirurgie vasculaire dans son évolution. Et les uns et les autres, parmi les équipes qui sont ici représentées, diront où est-ce qu'ils en sont dans cette évolution. Et dans les nouvelles technologies en particularité, dans la chirurgie conventionnelle et les nouvelles techniques, quelles sont les techniques qu'eux, ils utilisent dans leur centre en Afrique. Diapositive. Alors, la chirurgie vasculaire, bien entendu, prend en charge les maladies des vaisseaux, particulièrement celle de l'aorte abdominale, les carotides, les artériopathies des membres inférieurs, mais aussi les pathologies lymphoveineuses, c'est-à-dire essentiellement chez nous les varices, les lymphédèmes et les éléphantiasis. Diapositive suivante. Alors, les domaines d'expression sont essentiellement le cerveau, le cœur, avec l'aorte et les troncs supraortiques, le rein, le digestif, les membres supérieurs et de façon particulière les membres inférieurs. Suite. Alors, sur le plan de la prise en charge, il y a un bilan pré-chirurgical qui est fait d'exploration diagnostique, avec ici des contre-indications et des complications. Et en ce qui concerne la chirurgie, elle est soit conventionnelle, mais soit elle utilise de nouvelles technologies. Tout ceci concourt bien entendu aux soins qu'on apporte aux patients dans ces pathologies. Alors, les explorations diagnostiques comprennent la radiologie. Cette radiologie s'adresse à l'aorte, aux artères coronaires, au cerveau, au vaisseau des membres supérieurs, au vaisseau des membres inférieurs. En dehors donc de ces radiologies, il y a l'échographie, en plus ou moins couplée au Doppler, le scanner et l'imagerie par résonance magnétique. Diapositive suivante. Alors, voici une petite histoire de la chirurgie vasculaire pour nous donner une petite idée de comment les choses ont évolué. Diapo. Alors, au IIe siècle, c'est la nuit, première étape, la nuit de la chirurgie vasculaire. C'est l'étape de l'Antiquité au siècle des Lumières. Vous voyez qu'au IIe siècle après Jésus-Christ, c'était les ligatures artérielles qui se faisaient avec des boyaux d'animaux torsadés, écrits par Galien. En 1551 apparaît la pince angulée munie de morts antidérapantes, d'Ambroise Paré. En 1887, les pinces hémostatiques à crémaillère de Juppéan, que nous utilisons tous jusqu'aujourd'hui. En 1888, la suture par l'intérieur d'un anévrisme de l'aorte. L'étape 2, c'est l'étape de l'aube, qu'on appelle les révolutions du 19e siècle, avec l'apparition de l'anesthésie. L'anesthésie à l'éther de Morton en 1846. Ensuite, l'apparition de la sepsie et de l'antisepsie en 1856, avec les micro-organismes qui sont pris en charge sur le plan antibiotique par Louis Pasteur, et l'apparition de la radiologie avec, en 1995, la découverte des rayons X par Konrad Röntgen en particulier, et la première orthographie qui est réalisée en 1929 par Reinaldo dos Santos. L'aube, l'aurore, étape 3 sur le début du XXe siècle, avec les premières sutures artérielles. 1902, Alexis Carrel réalise la suture vasculaire par surjection angulaire. Ensuite, il y a la technique d'élargissement des artères. En 1924, René Le Riche est donc à la tête de la première école de physiologie vasculaire. Cette école qui a été développée aux États-Unis par Debaquet. L'étape 4, c'est le tournant, les années 40, avec l'apparition de la transfusion sanguine. La première transfusion sanguine est de Bloomsdale en 1829, Landsteiner en 1901, donc découle le groupe sanguin. 1941, le facteur rhésus, donc c'est une étape très importante. Ensuite, la pénicilline est découverte par Fleming en 1929 et les anticoagulants avec en 1940 l'héparine purifiée de Murray et Crawford. Alors, l'étape 5, c'est les 4 grande première chirurgicale dans le milieu du XXe siècle, avec en 1948 le premier pontage venu de neuropoplité qui est réalisé par Kunlin. En 1950, le premier remplacement bifurcation aortique de Udo. En 1952, la première endartérétomie carotidienne qui est réalisée par de Baquet. Et en 1952, la première prothèse artérielle synthétique. Sixième étape, c'est l'étape de l'essor de la chirurgie vasculaire, disons de 1960 à 1990. Apparaissent alors la sonde embolectomie de Fogarty, les premiers ballons de dilatation, la prothèse en polytétrafluoroéthylène en 1976, les endoprothèses, c'est-à-dire les stents qui apparaissent dans l'année 1987, les endoprothèses couvertes et autres anti-agrégants plaquettaires, fibrinolytiques, etc. Donc, la chirurgie conventionnelle et la chirurgie endovasculaire sont les deux moyens utilisés pour la prise en charge de ces patients. Alors, la chirurgie conventionnelle la plus ancienne, c'est la technique de première intention et donc la technique de référence. C'est l'abord direct de la lésion dite à ciel ouvert et les gestes qui sont ici réalisés, ce sont des gestes de mise à plat, par exemple mise à plat greffe, généralement réalisés dans la chirurgie aortique, soit des pontages en bypass ou des endartérétomies, ce sont les gestes de base. Ici, la chirurgie conventionnelle, en cas d'échec et de contre-indication, normalement de la chirurgie endovasculaire, ce ne devrait être que ça les indications de la chirurgie conventionnelle. Les avantages de cette chirurgie conventionnelle sont quand même certains. C'est la visibilité, c'est le contrôle visuel et direct de la lésion, mais les inconvénients, c'est que c'est une chirurgie invasive qui peut être considérée comme agressive, qui a un certain coût, qui est souvent émaillé de complications, complications infectieuses, complications hémorragiques, et les délais d'hospitalisation sont longs, donc il y a un coût dans la prise en charge hospitalière. Alors, la chirurgie endovasculaire représente donc un progrès majeur, particulièrement dans la pathologie aortique. Dans le début des années 80, cette chirurgie s'est développée. Il s'agit d'un abord indirect de la lésion. Ici, l'anévrisme n'est plus abordé directement, n'est plus disséqué. On n'a plus besoin donc d'attendre ou de risquer la rupture. Il y a cependant un conflit avec les opérateurs. Qui c'est qui fait l'opération? Est-ce que c'est le chirurgien vasculaire? Est-ce que c'est le radiologue? Diapositive suivante. Alors, la chirurgie endovasculaire permet la pose d'endoprothèses, la pose de ballons, de coils, de stents. Et ici, il y a de nombreux avantages. Elle peut être réalisée donc dans les cas d'urgence, chez des patients qui ne sont pas dans un état général très bon, chez des patients avec une comorbidité faible. La comorbidité est faible, donc après réalisation de chirurgie endovasculaire, les frais d'hospitalisation sont moindres puisque généralement la durée d'hospitalisation est courte, délai court d'intervention, délai court d'hospitalisation. Ici, les inconvénients peuvent être donc cités dans les lésions étendues et dans la disponibilité matérielle et l'entretien de matériel en Afrique. Bon, on a vu tout à l'heure qu'il y avait des lésions étendues qui ont été traitées par cette technique. Donc, là où il y a des centres qui ont les moyens, ça ne devient pas un inconvénient. C'est ce que le docteur Veller nous a dit. Maintenant, qu'est-ce qu'il y a comme nouvelle avancée? Les nouvelles avancées donc tiennent lieu de la possibilité d'utiliser de nouvelles technologies. C'est ici la chirurgie mini-invasive. Alors, cette chirurgie mini-invasive, c'est la celluliochirurgie, qu'elle soit laparoscopique ou qu'elle soit thoracoscopique. Les nouvelles technologies, c'est la chirurgie robotique. Mais en définitive, entre la celluliochirurgie, l'essentiel, ce qui aurait été bien, c'est le tout celluloscopique, mais nous nous rendons compte que c'est très difficile d'atteindre le tout celluloscopique. Ce serait plutôt alors une chirurgie hybride. Suivant, par exemple, ici dans la chirurgie laparoscopique de la aorte, vous voyez la position donc, du patient et des opérateurs. Suivant, diapositive suivante. Voilà, voilà une chirurgie laparoscopique de la aorte. Vous voyez ici la cavité abdominale et avec, on a récliné les os et on voit la aorte abdominale. Suivant. Alors, là, liée à la chirurgie aortique. En 1993, Dion a réalisé le premier pontage bifémoro-aortique laparoscopique assisté. Alors, le développement de procédures laparoscopiques assistées, comme la mini-laparotomie, le développement de procédures totalement laparoscopiques. Alors, donc, c'est ce qui a été essayé et on n'est pas arrivé à développer cette procédure totalement laparoscopique. Le challenge de cette chirurgie robotique, c'est la courbe d'apprentissage qui est longue parce qu'il n'y a pas assez d'exposition et parce que c'est difficile d'atteindre donc, d'avoir la technique pour pouvoir réaliser cette chirurgie robotique. La longueur de la procédure, vous savez, c'est généralement des patients qui ont des comorbidités et à la longueur de l'anesthésie. Et la procédure elle-même, elle est longue, la fatigabilité de l'opérateur et de l'équipe d'intervention. Alors, la grosse difficulté, c'est la réalisation de l'anastomose aortique et la gestion du temps de clampage aortique. Suivant. Alors, les autres limites de cette chirurgie tiennent à l'instrumentation. Alors, le guidage visuel est indirect, donc il n'est pas évident. Il y a les sensations tactiles qui sont complètement modifiées. Donc, c'est une chirurgie sur le plan de l'instrumentation qui est peu ergonomique puisqu'il y a une perte de l'articulation, axe bras, poignet, main, donc les sensations tactiles. Et l'autre limite, c'est la celluloscopie. Avec la complexité de cette procédure, la durée de l'opération et sans compter le risque de conversion. Alors, donc, la chirurgie hybride, c'est donc une alternative. Ce serait donc une combinaison entre la chirurgie conventionnelle, qui ne doit être normalement indiquée qu'en cas de contre-indication de chirurgie laparoscopique ou endovasculaire, et la chirurgie robotique. Il faudrait essayer donc de développer et tout reste à faire. Nous venons de voir les difficultés. Suivant, en conclusion, les nouvelles avancées en chirurgie vasculaire se résument à cette chirurgie robotique, mais le but véritable serait la réalisation du tout celluloscopique. L'expérience, et nous venons de voir, montre que cela demeure une vue de l'esprit. Donc, ces difficultés du tout celluloscopique sont manifestes dans la chirurgie aortique qui en est la première indication. Les risques de complications sont alors à mettre en balance avec l'objectif qui est de traiter la plainte du patient. les procédures hybrides qui concilient ces différents facteurs demeurent donc une piste intéressante de recherche. Alors, en ce qui concerne notre expérience au Gabon, toute cette problématique se pose. En fait, ça, c'est une présentation que j'ai faite pour profiter de la présence dans cette salle des différentes équipes de chirurgie vasculaire pour qu'elles nous disent quelle est leur expérience en la matière. Je vous remercie.
Merci au professeur Ndong pour sa brillante présentation. Professeur, j'ai pris la présentation en cours, mais je l'ai trouvée très, très intéressante. Et je voudrais vous poser une question concernant la chirurgie. Vous la faites avant?
Réponse non.
D'accord. Et la chirurgie endovasculaire?
Alors, la chirurgie endovasculaire, la réponse, c'est non. Nous essayons de mettre en place, parce que le problème avec la chirurgie endovasculaire, c'est la collaboration avec les radiologues, la radiologie vasculaire. Et nous y sommes, nous essayons de monter une équipe qui travaille en collaboration avec l'équipe de radiologie pour pouvoir commencer ce genre de procédure.
D'accord. Parce que nous, en Côte d'Ivoire, depuis à peu près 2 ans, nous travaillons en collaboration avec un médecin français d'origine ivoirienne. Je pense qu'il a fait déjà quelques séjours au Gabon pour faire de l'endovasculaire. C'est vrai qu'au départ, l'endovasculaire était réservé aux patients qui présentaient des contre-indications de la chirurgie ouverte. Mais il se trouve qu'aujourd'hui, finalement, c'est une avancée considérable. Ça permet quand même aux patients, même ceux qui ne présentent pas de contre-indication à la chirurgie, d'en profiter. Le seul inconvénient de cette technique, c'est le coût des intrants. Là où une chirurgie ouverte avec peut-être 3 à 4 millions de dans une chirurgie endovasculaire, si en plus on est obligé de mettre plusieurs prothèses, ça coûte excessivement cher. On peut passer d'une prothèse, les prothèses sont autour de 7 millions. 7 millions. Donc, si vous mettez 3 prothèses, on est déjà à 21 millions. Mais, comme on dit, la médecine a un coût, même si la vie n'a pas de prix. La médecine a un coût. Et je pense que c'est une très, très grande avancée qui permettra aux patients, surtout qu'aujourd'hui, nous avons des populations qui vivent de plus en plus longtemps. Il y a certains qui ont les moyens qui peuvent profiter de cette technique. Voilà. Je voudrais passer la parole à l'auditoire. Quels sont ceux qui ont des questions à poser au professeur Ndong, s'il vous plaît? Concernant les endactylectomies carotidiennes, vous en faites beaucoup avant?
Nous n'en faisons pas beaucoup pour la simple raison que les pathologies des ponts supraortiques sont assez rares, hein, en tout cas dans notre expérience au Gabon. Je ne sais pas quelle est la situation en Côte d'Ivoire, mais non, c'est assez rare.
Je n'ai pas les chiffres en tête, mais avec les neurologues, on a eu plusieurs rencontres pour les indications des accidents vasculaires cérébro-ischémiques sont souvent dues à des lésions carotidiennes et on en a opéré quelques cas. Généralement, c'est à visée préventive parce que c'est pour éviter les récidives. Les malades ont déjà présenté un accident vasculaire cérébral, mais pour éviter qu'il y ait des récidives, on peut les sauver. Voilà. S'il n'y a pas d'autres questions, vous avez d'autres questions dans la salle? Bon, ben, professeur, merci de nous avoir enrichis. Est-ce qu'il est prêt? La technique est prête pour la dernière communication de M. Joël Duning.
Hello.
C'est bon? C'est prêt? Are you ready?
Yes, I'm ready. Yeah, shall I?
Donc, M. Joël Duning va nous parler des techniques modernes en chirurgie thoracique. Mr. Duning, you can start.
Okay, thank you very much. I'll share my screen and then we'll get there. See if you can see my screen. And I wonder if you can see my screen rather than vascular surgery. That was the previous talk.
Yes, we can see your screen.
Okay, great. Well, I'm going to tell you about the current status of thoracic lung surgery in the Western societies. And then just for a little bit extra, for those of you who are just cardiac, I'm going to tell you a little bit about an amazing new pacing opportunity for everybody in the room. So don't go to sleep. So I'll just start with two papers that have been massive in Europe and America. The first massive paper has been this study where we've finally done a randomized study of open thoracotomy versus minimally invasive surgery. So we randomized 500 patients into either minimally invasive surgery or thoracotomy. And we looked at how they did for post-operatively, and basically we have finally proven that there is a reduced length of stay, reduced pain with exactly equivalent outcomes. And you're seeing my slides okay? That says Violet trial, is that correct? Yeah.
Yes, it does.
Yeah, great, thanks. So that was an amazing study that actually finally shows us that it is safer and better to do minimally invasive surgery in lung cancer. The second really wacky study that we're all having a lot of trouble understanding is this amazing study by the Japanese. They have spent 15 years doing this study. They randomized 1,000 patients. And for patients with lung cancer less than 2 centimeters in their lung, they were randomized to either doing a lobectomy or a segmentectomy, taking just a small part of the lung, because in Japan, they love to do minimally invasive surgery. And the crazy thing about this study, which we're having a lot of trouble getting our heads around, is that amazingly, there is a better survival in the segmentectomy, take a smaller amount of lung away group. It says that you should do a segmentectomy rather than a lobectomy, a much more difficult procedure, smaller resection margins, but you survive better if you do a segmentectomy, much more difficult to do as well. The thing we're trying to get our heads around is that while there's a 3% better survival, there's a 3% increased recurrence rate. So there's more recurrence rate, but better survival. And that's kind of strange, but actually this in the West is going to lead to a huge rush towards doing less invasive surgery and taking less lung. So we've spent many years doing thoracotomies. The other thing the Violet study showed is that actually thoracotomy is not a bad procedure. There was no increased death rate compared to minimally invasive. It was only 1 day less in hospital for minimally invasive, and it was only a little bit less pain and a little bit less opiates. So if you do thoracotomies for thoracic surgery, do not be despondent. Do not feel that you are doing something too terrible, because actually the two groups were much more similar than you would have thought. But now we're all going much more quickly towards minimally invasive surgery. We're getting to 70–80% rates in the Western world. And we've started off with 3-port approaches. We've gone to 1-port approaches. Well, I'm sure you know Diego Gonzalez Rivas. If you do thoracotomies, he's taught the world to do this in just about 9 years from it being invented to being 40% of the world's minimally invasive surgery of VATS is uniportal. But there's loads of other ways of doing it. In China, they do it subxiphoid, not a single incision in the chest. I have my own version of doing lobectomies by VATS, and these are just 5mm incisions. I've got a little camera holder, and it's all very relaxed and calm. You can see my friends in the background sitting there chatting and using very small incisions. We've all got new and wacky ways of doing it. Here's the craziest way I've ever seen. This is an incision in the neck. This is looking down the neck into the right chest. And that's the diaphragm in the distance and the right lung and the rib cage. There's a crazy guy called Marian Zielinski in Poland that can do right-sided lobectomies and left-sided lobectomies from a pure cervical incision. So isn't that incredible? And that's the pulmonary artery you're seeing pulsating away, and the SVC in the azygos. And that's the pulmonary artery truncal branch being stitched only through the neck. Isn't that crazy? There's a guy in France that does it subxiphoid with 2 incisions, all sorts of different approaches. Here's a little modification of my technique where you have a 3-port approach, but we've now got wristed instruments. So this beautiful little thing is a really good wristed instrument. This is called FlexDex Surgical, really good in thoracics, but also if you're a mitral surgeon, this is a great suturing device in a port access mitral. If you'd say had a previous thoracotomy or something, a really good, interesting device to try and use. We've tried to recreate almost a robot without a robot. So I've got on my head, I can control my camera. So my camera holder is actually being controlled by movements from my head. I've got my robotic style wristed instrument in my hands. And so I can virtually do robotic surgery without a robot. If I've got a camera holder, I've got this wristed instrument, then really I can do virtually everything that a robot can do without the £1.3 million expense of a robot. So there's lots of ways you can do things without necessarily spending huge amounts of money. And you can see this is lovely. This is a diaphragm plication, but equally you could do this in a huge number of endoscopic suturing techniques. A lot of esophageal surgeons use this, cardiac surgeons use it, and it's widely used for ventral hernias in the abdomen. There's a new device out that's much better than that. This is called the Articentrial wristed instrument, modeled by my wonderful scrub nurse, and it is brilliantly wristed, but also you're not stuck, so you can use one in either hand. So whereas the other instrument was stuck to your wrist, so you couldn't have 2, this has 2 wristed instruments and a camera holder. So this is really now getting very close to robotic surgery. And if I showed you this video, you would probably be mistaken for thinking this was a robot doing the operation, which it isn't. And actually, although these instruments are about 500 quid, I reckon they could probably be reused about 20, 30 times in any countries that accept recycling instruments, which is quite a few. And you can see they're brilliant for getting round vessels in a lovely way. Now, we're in the West, so we get very excited about robotic surgery, and I'm sure you love to see this robotic surgery. These are tremendously expensive devices. These are used to save one day in hospital, to save a little bit more pain. But now we are rocketing in the West very, very quickly towards full robotic surgery and all thoracic surgery. So currently in the UK, we're at about 60 to 70% VATS, and we're at about 10% robotic. But the robotic surgery is doing the exact same curve that VATS did 5 years ago. It's coming up massively fast. Every single unit in the UK, apart from 3, have either bought or is just about to buy a robot. And why is it so great? Well, it's quite easy to set up. Here's me just setting it up. We bang all our arms in, and then it feels like being an open surgeon. Once you've got all these arms in, you go down and sit on a console, and it's actually like moving your hands in the chest. It's tremendously easy. It's very detailed. And one thing that's really good is to do these difficult operations like segmentectomies. And actually, it's quite relaxing. So this is my assistant, just relaxed, chilled, looking at the screen. I'm sat down doing the operation. And it is a lovely, great way to do it if you can get access. Now, the reason I'm showing you this is because there's a massive avalanche towards cheaper robots. Cambridge Medical Robotics is a company I'm involved with, and they have designed a smaller, cheaper robot. These are small little consoles that all sit by the bedside, and you can have 2 or 3 or even 1 if you just want it to be a camera holder, but you can have up to 6. They've got all these instruments. And this is it in our research lab on a cadaver, and it's smaller and it's cheaper and it's more versatile and it's more movable, and it's already half price compared to the intuitive robot. There's a few other small little advantages. You can stand up on your console. It's a nice open screen, so you can actually stay scrubbed. I'm actually scrubbed, so I can actually just come straight to the table, and this is all sterilized, and go and do some stuff at the table and then go back. So there's lots of little advantages, but actually the main thing is that this is becoming more accessible. Medtronic, with all its massive buying power, has just entered the market of robotics by this robot that's called Hugo. And they really, really want to disrupt the system. They want this to be in every hospital in the West, and they're going to come in. Anybody that uses Medtronic equipment, they're going to come to you saying, sign an exclusive deal so you don't use Johnson & Johnson, and we might give you a free robot. So this is, again, one to watch. And they're already out. They use all their standard Medtronic kits, ligatures, Covidian staplers, so they're great. Johnson & Johnson, not to be outdone, are there creating a whole ecosystem called Verb Surgical. They say they're more than a robotic platform. They're going to promise enhanced visualization, data analytics, all sorts of things. So I've been out and visited them. They're unfortunately a few years away, but again, the market is getting flooded with these things. This is my particular favorite. This is a uniportal robot. Out of one hole comes 3 arms and a camera. And I've used this through a single subxiphoid incision, and it's genuinely the best lobectomy I've ever done. It's a truly phenomenal piece of engineering at a phenomenal price of $800,000 as an addition to your $1.3 million intuitive system. But I want to get on to some things a little bit more interesting for you, perhaps. And the real interesting thing about COVID is what it's actually done for mentoring. So I've now become a remote telementor. So this is me in my kitchen. I'm actually mentoring a Cambridge Medical robotic operation in Chemnitz in Germany. I have never yet met Sven Seifert in person. I've helped him to start off his program, and from having done 0 minimally invasive robotic operations with CMR Surgical, he is now routinely doing those operations fully by doing what, to all intents and purposes, looks like a Zoom call. This particular platform is called Proximy. There's another one called Reacts. There's actually loads of them. And actually, once the technology failed us, and we actually set up a Teams call, we just put 4 laptops in the operating room. We got one person with an iPhone videoing from the bedside, and they phoned me on Teams. So actually, that is accessible today. If you want some Western proctors to come and watch your operation, you could actually do it completely cost-free with a Teams or a Zoom call, about 4 laptops and a few iPhones. Generally, you could do that. And I would genuinely be happy to take part in something like that. we've just invested in this headset. Now, what is this crazy little headset called Vuzix? Well, what this crazy little headset does, it allows you to be in my operating room. I can wear this. You'd be on that laptop down there. We provide you a link. I can see the laptop screen in my little visor there. I can actually also see you emailing me questions. I can hear you in my ear saying, oh, can you move left a bit? Can you move right a bit? What are you doing with those stitches? But you can actually do a call into my operating room and actually do a proper one-on-one immersion now with this gadget, which is by Vuzix by Johnson & Johnson. There's another one called Rods and Cones. These are actually really affordable, really cheap, and all you need is an enthusiastic surgeon to say, come and watch my operation, come and learn. And just before we go to that, we're actually going to Ghana, to Accra on the 12th of March. We're actually hoping to bring this Rods and Cones setup, and we're hoping to leave behind a telementorable system so that Abidjan at UGMC can be helped to start a safely proctored cardiac program there in Accra. So this is really happening today, and it's really possible. Just a few little tiny notes on what else is happening. The other thing that's happening massively in the West is lung cancer screening. At the moment, we only find 20% of lung cancers at a curable stage. And I'm sure that's even less in the African continent because people come late. And that needs to change. We've proven with multiple studies that if you start screening anybody that smokes beyond about 50, if they have a CT scan every 2 years, their chance of having a treatable cancer found goes from 25% to about 80%. So, and if you scan all smokers above about 50 years old, you will find a lung cancer 1 in 80. The amazing thing is that in China, where it's commercially available, loads of Chinese go for 30 quid and have CT scans, and their resectable lung cancer rate has just rocketed through the roof. They're really making a difference in lung cancer. We're doing loads of studies to try and make our operations better. Now, these are robotic studies, but they don't have to be. They could be studies in open surgery and in anything, because the really great thing is every single major supplier, that's Medtronic, Johnson & Johnson and Intuitive, are all trying to create ways to collect our videos and then get them mentored. And I'm actually part of this website called csats.com. It's set up by Johnson & Johnson, and people put their videos on this, mostly endoscopic, but if you put an endoscopic video already, it will list how long it's taken you to do all these steps. This is done in a semi-automated fashion. It then gets sent to me as an expert, and I review it, and I write a review on your operation. Now, mostly it's endoscopic, but it doesn't have to be. I've had a few open operations on this platform. This could be cardiac, this could be anything. There are loads of platforms being created now where you can send off your videos for mentoring at a later date. This particular platform actually comes up with a score in 4 different areas. So you get a score for your depth perception, your efficiency, your sensitivity, and you get a written report by somebody like me. So you can tell people, you know, I'm doing really well at this operation. I'm 20 out of 25. Or maybe you can submit a really difficult operation that you only scored 12. And the amazing thing is this program can go and find other operations just like that for you to look at and try and see what could I have done better. So there's this massive library and it filters it by the operation you've just done. So go and look up other operations that you didn't quite get the good scores at. I think this could be an amazing facility for learning worldwide. And it doesn't have to be minimally invasive. It can be anything. In fact, you could just put your videos on YouTube and ask me to look at them. If you do thoracic surgery, you could. Just in the last 5-10 minutes, the world has changed so much in COVID. And one thing that really changed is online learning. We've set up 40-hour-long online learning programs for our nurses. This is a 40-hour program in thoracic nursing. E-learning at csuals.org, and it's all there. It's you've got post-op care, intraoperative care, deteriorating patient, chest drain management, analgesia, blood gases, all there online. If you've got a phone, you can do this learning. And we've actually got this in cardiac, we've got it actually in cardiology, cath labs, And we've actually just started one in emergency medicine as well, all available online and available right now. So the world of training and learning has really opened up, and it really needs to get to people that don't access this in person. We're even doing other strange things like acupuncture in thoracic surgery. And that's a little strange thing. And we also provide our patients now with apps that we've set up ourselves to guide them through their operative process. And I guess potentially this doesn't have to be just for our hospital. I could actually log somebody with an email in Abidjan. Someone about to have a lobectomy in Abidjan, they could go through this, the complications of surgery, the alternatives to surgery, all sorts of useful things, because this is free to our patients, and I could log anybody onto this. So maybe in an ideal world, I'd have this for the whole world, and anybody could just log on and go and find helpful things. Because the really good thing about this is it tracks the patient afterwards. It asks them how's their pain and their medications post-operatively for about 2 weeks afterwards. It then asks the quality of life questionnaire automatedly. And then every 3 months for 5 years, it's going to ask them if they're coughed up any blood, if they're short of breath, and if they're worried about recurrence for cancer. And if they tick yes, it's going to send me an email. No effort, no cost. And I think that's really exciting. So that's just something that, we should all try to engage. Now, if you'll allow me, just for the last 5 minutes, I want to tell you about a really exciting charity that I'm involved with, and it's called Pace for Life. Pace for Life has started reprocessing pacemakers. 30,000 pacemakers go to crematoria in the UK. And we've set up a system to collect them all centrally. We check them, and we check them with our interrogators, and we find that loads of these have loads of battery life. Here's an example, the Medtronic Azure. This has 15 years of battery life when the person that pre-owned it died. We've got a system to find loads of them. So here's a whole load of them, all with 15 years of battery life. We send these to America, where they've got an FDA-approved process to recondition them. They take out the screws, they recondition everything, they clean it, they go to an FDA-approved sterilized system, and they send them back to us. So I'm taking these 20 to Accra on the 12th of March, and I'm going to give them to the surgeons there for those who can't afford pacemakers. And I hope that'll make a difference. There's a group called Pascal that we're trying to promote this through, and already we're sending them to Kenya, Sierra Leone. And if you have some cardiologists that you think might benefit from free pacemakers, these are free and the wires are free, then I would love to hear from them. So please do get them involved. Send us an email to paceforlife.org. The first step is start implanting free pacemakers. Then the second step is that we've set up an amazing RCT. In this randomized study, a patient who can't afford a pacemaker is randomized to a reconditioned pacemaker, which will last them 15 years, and we guarantee to send them another if it runs out of batteries, or a brand new pacemaker. Medtronic is paying for this. It'll all be free. And the amazing thing is that every time you follow up your patient, which can be every 2 weeks, you'll get $50, even if that's just a phone call. So I think this is a great opportunity. And even if you don't personally put pacemakers in, please do get your cardiologists involved. So I'll stop there, and thank you very much for the invitation to talk today.
Thank you, Mr. Jing, for your presentation. On va continuer en français. Très belle présentation où vous nous avez présenté les nouvelles techniques de chirurgie thoracique, surtout dans le traitement du cancer. Nous, en chirurgie thoracique, les interventions que nous séquelles de tuberculose. Les séquelles de tuberculose et généralement tuberculose et l'accès souvent au thorax est extrêmement difficile. Je voudrais savoir si vous avez, dans la prise en charge par vidéo, des exérèses pulmonaire post-tuberculose.
Yeah, so I think the question there was you get a lot of tuberculosis and how we can help. And yeah, you're totally right. There's often a completely fused thoracic cavity. I would personally say that my message, I would say that my message would be that don't worry too much about doing an open operation. I think it's very difficult to treat those patients minimally invasively. I think you should just pay really good attention to pain relief, really good intercostal blocks, bupivacaine in every single intercostal space, an injection to the phrenic nerve, an injection to the vagus, and we would always do a catheter infusing local anesthetic to either the pleura or to the erector spinae muscle. So there's still a lot of hints and tips, even for open surgeons, that we can provide.
La traduction n'est pas passée. Donc, si tu peux faire le relais, comme ça, on va...
Joel Dunning, can you hear me?
Hello. Yes,
Hello?
I can hear you.
So
yes,
the first question was the first question was about tuberculosis, lung tuberculosis. The question is, do you think that there is a place, something, the indication for this your techniques to be used in case of tuberculosis, lung tuberculosis, or destroyed lung by tuberculosis?
Yeah, and it's a very common condition in Africa. And my answer would be that actually, if I was working in Africa, I would do thoracotomy, but I would spend a lot of time on pain relief. I would make sure we had really good intercostal blocks at the start to all 12 intercostal nerves. We give bupivacaine, dexamethasone, magnesium, clonidine, and steroids to our intercostal spaces. We inject the phrenic nerve, the vagus nerve, and we put catheters in the under the erector spinae muscle for pain relief. I think it would be extremely difficult to routinely do minimally invasive surgery in tuberculosis unless you had a huge amount of experience, and the benefits may outweigh the risks.
Thank you for your answer. And I want to thank you sincerely, because what you present is amazing. About screening for the lung cancer, I think that can be a very good option in sub-Saharan Africa. What do you think?
Yeah, so if I was trying to start that
the diagnosis here is often the diagnosis is very late, you see, because of lack of screening in case of lung cancer. What do you think indication here? You see, I want to comment your comment about that contribution and so.
So yeah, the big challenge is finding lung cancer early. And certainly I think in your environment, a lot of people present late. The message is to try and get people to come and have CT scans as early as they possibly can, especially if they're smokers. We have this challenge now where we're trying to get people to come and have screening scans. We use the families to try and persuade their fathers to come for scans, and we have public health messages. So in the UK we have campaigns, cough campaigns. If you've coughed for 3 weeks or more, come and have a scan. If you've coughed up blood, come and have a scan. Or we go into schools and say, if your father or grandfather has had a problem, come and have a scan. If scans are cheap, then even smokers who are 50 years old or older should just get a scan every 2 years if they can afford it. That would be my advice for trying to get these detected, because most of the patients I operate on, their cancer was found by luck, not by presenting with symptoms.
Okay, but have you some study with the comparison between screening by CT versus screening by robotic or the new technology?
So the Nelson trial and the American NLST lung cancer screening trial were both trials of chest X-ray versus CT scan, and they showed a massive survival benefit for using CT scanning to screen anybody over 50 who smokes for lung cancer. So I would say, if any of you see a patient who smokes over the age of 50, and if they can afford it, make sure they get a CT scan of the thorax. 1 in 80 of their scans will find something abnormal.
Okay. Okay. So
est-ce qu'il y a d'autres questions dans la salle? Ouédé, toi, le spécialiste de la vidéo, tu as quelque chose à dire? Je suis? Bon, d'accord. Nous allons dire donc merci à monsieur Joël Dunning pour nous avoir enrichi cet après-midi avec sa communication. Très belle communication. Merci beaucoup et bonne soirée. Mr. Tete, are you ready for your presentation? D'accord. Voilà, au moins que ce soit affiché. Et puis après.
Professeur Tete, tu peux le présenter? Professor Tete Mark is an associate professor of surgery in Cardiothoracic Division at the University of Ghana Medical School. Is now the head of the Department of Surgery, and is a pioneer of the new generation of in cardiac and thoracic surgery in Accra. Is very involved in thoracic. His contribution, huge contribution for Africans about esophagus. He has contributed a lot. That's why it's a great pleasure for me to introduce Professor Tete for this very great progress that he has made for all the benefits of our patients about esophagus cancer, esophagus cancer. So, Professor Tete, you have the floor. And Professor Tete, let me tell you that he was the president of the chairman of the LOC during the inaugural international conference of our association. Is now very involved in the activity of this association. So it's a great honor for me, a great pleasure to give the floor to Professor Tete.
Yes, thank you very much, Professor Ngati. And I really I'm really indebted to you for this opportunity you've given me to present my work in the Cardiothoracic Center in Accra. Today, I'm going to be presenting something that I termed colon flap augmentation pharyngoesophagoplasty for severe pharyngoesophageal injuries. You'll hear, I'm sure the time is almost gone, so I would not like to take much of your time. I'll be very snappy as much as possible in this presentation. Next slide. Okay, while they are working on that, there was a publication in the Lancet by one of the consultants in when it comes to pharyngoesophageoplasty or pharyngoplasties, Marcia Chirika. I hope I've pronounced it well. It was 2016 in the Lancet, and that it was a review article on caustic injection. As part of the review, there was a section that talked about low-income countries. And I just want to read what he put down there. In low-income countries, specific issues including delays in management, limited access to medical expertise and technology, and poor follow-up have a negative effect on clinical outcome. These factors should be taken into account when planning management of caustic injuries in low-income countries. Children are often involved in esophageal strictures, requiring repeat dilatations are the most common form of presentation. Introduction of complex endoscopic treatments and surgical procedures in the absence of a suitable hospital environment warrants caution. Under such circumstances, simple interventions such as placement of surgical gastrostomy should be favored because they might help avoid malnutrition and prolong survival. So you realize that, yes, you realize that the perception of the consultants out there, those who know how to do this surgery, is quite a complex surgery. The perception out there is they feel for the low-income countries, and they are not very confident that we can do such surgeries. That is how we were at the National Cardiothoracic Center in Ghana some years back, where those children who swallowed caustic soda with severe pharyngoesophageal injuries were condemned to their fate. They cannot swallow any longer. The only way they could feed was through the feeding gastrostomy tube. And some of them even had permanent tracheostomy. And that was what we had a few patients lying or coming to the OPD with. And it's a sight that you would not want to see, because they come and you realize that that is how they are going to be living for the rest of their lives. And that is what gave birth to the center going into colopharyngoplasty. I had to talk to my trainer, that's Professor Frimbo Boateng, and my colleagues, and they encouraged me, and I started that. Can we go to the next slide? I practice at the Cardiothoracic Center. That's the front view, and the front view of the Kolego Teaching Hospital. That's supposed to be the biggest hospital in Ghana. Next slide. Next slide. So that's what I've just read to you. Next slide. So this evening, I'm going to, after introduction, I want to look at the challenges of patients with severe caustic pharyngoesophageal injury, the spectrum of presentation of these patients, and then surgical options worldwide, and then colopharyngoplasty in Ghana. I'd like to tell a short story, and also what I've brought on board, and then recommendation, conclusions, references, and acknowledgement. Next slide. Next slide, please. Now, pharyngoesophageal injuries present as a double-edged problem. And these are patient devastation and management difficulties. Patient devastation, we are looking at patients, these children or these patients who are unable to swallow their own saliva. And they have to carry sputum mag wherever they go. And the other problem they have is breathing challenges sometimes, because they have to put tracheostomy in there for them to be able to breathe. So the devastation of the patient is a big challenge. And if you have ever seen one, the misery on their faces tells a lot. And the other thing is management challenges. Management challenges, why are we saying that? Because preserving and restoring the airway at the same time restoring swallowing can become a big problem. Because we all know how the trachea and the esophagus evolve. Initially, it was one tube, supposed to be one tube, but then separated along the line. And the anatomy of the mouth and the muscles that coordinate for us to be able to swallow without aspiration is so fine. So much so that if this is destroyed by caustic injection and you want to restore normalcy, it becomes a big challenge. Because patients often, after you restore something, patients often aspirate when they want to swallow. So there's no standard procedure really for management of these injuries. And but over the years, management has evolved, mainly tailored according to the severity of patients and what they presented with. Next slide. Even though the airway is essential for survival, sometimes we have to sacrifice that. Most patients would like to have a tracheostomy if they have to choose between tracheostomy and feeding gastrostomy, because carrying the sputum mask and wearing the feeding tube, especially when they cannot taste food and swallow, it's a big challenge for them. So it's easier to breathe through a tracheostomy than to feed through feeding gastrostomy. So the challenge for the surgeon is to do the best possible to restore near normal life after severe caustic pharyngoesophageal injury. So this evening, I'm just going to tell you the story how we also started and how we have come with an improved procedure which appears to be better than what is even practiced in the world now. Now, what are the challenges? The critical challenges of the patient who presents with severe caustic pharyngoesophageal injury. We have structural damage and functional damage. Structural damage, we have patients who present with destruction of the larynx. We have fibrosis in the pharynx, fibrosis of the base of the tongue, and we have stricture, sometimes complete stricture of the hypopharynx, and sometimes we have partial stricture of the hypopharynx with the esophagus or some stricture, some lumen in the proximal esophagus. So we have varying degrees of structural damage after this caustic injection. Then we have functional damage. Some of these patients are unable to breathe, and then most of them they are unable to swallow. We have restriction of muscles of swallowing because of the scarring, extensive scarring that occurs. And sometimes because of the stricture that is experienced in the hypopharynx, patient could swallow sometimes saliva and little liquid and all that, but immediately they want to swallow a larger volume of food, there is reflux into the airway that may cause aspiration, apart from cases where they have complete obturation of so the spectrum of problems that we see in these patients are mainly in three areas. We have patients who come with permanent tracheostomy with varying degrees of pharyngeal esophageal injuries. And then we have patients who have preserved airway, and then with varying degrees of esophageal injuries. And then we have patients with isolated pharyngeal strictures. And each of these can be subdivided depending on the type of injury that the patient presents. Next slide, please. Next slide. So what do we see out there? The surgical options that are employed out there. We have one serial dilatation followed by colopharyngoplasty, where you have some lumen in the pharynx. Some authorities chose to do serial dilatation. The reason for doing that is to try to improve on the lumen at the pharyngeal level so that they can do anastomosis close to the esophagus. And this is known to help prevent aspiration. And then we have multitudinous flap pharyngoplasties for isolated pharyngeal strictures. And sometimes also it is used to repair the pharynx, and then later they do a colon anastomosis to these multitudinous flaps. So pectoralis major is used, stenoid with mastoid multitudinous flaps are used. And then we have the colopharyngoplasties with or without tracheostomy. Now the WHO advises that when you are going to do a colopharyngoplasty, you have to put in a tracheostomy to protect the airway. And that's where we had a problem. And our initial publication on this, I would explain that when I'm talking about it. And then the final thing is the colon flap pharyngoplasty, which I have got on with my colleagues. So the step down, these are some of the publications we have. The step down approach that uses the dilatation to step down where you're going to put your colon anastomosis. And then we have the pharyngeal esophageal strictures used constructed by multitudinous flaps. And there's this man who is also a very big authority. They are the pioneers of colopharyngoplasty, Zenopopovisi. I hope I've pronounced well. And he also did a lot in colopharyngoplasty. And he also could do laryngectomies and use the colon to reconstruct the pharynx. And then we have another authority, that's Messier Tarika. He did a review and I read for you, and also another authority in colopharyngoplasty. Now, at the National Cardiothoracic Center, what are the indications? It's not different from what I've told you initially. Patients come with permanent tracheostomy with pharyngeal esophageal strictures, varying degrees of that. And so they come with tracheostomy and feeding gastroscopy. Some years back, these patients are just left to their fate. And then we have other patients with preserved airway and also with different degrees of pharyngeal esophageal strictures. All these patients we see swallowed caustic soda. Now, for our patients, what we do for them, we operate them at least 6 months after the injury. Preparation of surgery is very obvious to us. About preparation, we use Mantle, and we elect to do a sphincterectomy. We elect not to do a sphincterectomy, sorry, because those who do a sphincterectomy, they think this patient might develop cancers in the future. But then when we look at the cases we do, most of them have complete destruction of the esophagus, and the mucosa that is supposed to degenerate into cancer usually is destroyed. So we do not think there's anything there to even develop a cancer in the future. And the other thing also, there's a lot of periesophageal fibrosis, and the morbidity of sphincterectomy is quite high. So we just like to avoid that. And then we use a left colon for most of our patients. And before we do the surgery, intra-op, we inspect the pharynx and then make our mind on what to do. Barium swallow in such patients is not something we routinely do, but sometimes we try to find out what is going on there. But then, because most of our patients cannot swallow, and if you give them the barium, they can't even swallow it. So, but then sometimes you use very thin NG tube to help us especially if you want to know what is going on. So what happened in 2006 was we opened the pharynx of patients with this type of injury, this extensive injury. And most of them were above the hyoid, so these suprahyoid colopharyngoplasties. And we can see it from, hey, can you? Yeah, please go on. Yes. So we open the pharynx and then bevel the end of the colon. The colon is we always root it retrosternally. And at the end we bevel it and then do the anastomosis at the pharyngeal level, just above where the stenosis or the stricture ends. And that is how we solve the problem of our initial patients. So the first colopharyngoplasty we did was in 2006. And the first analysis was of the first 5 was published in 2011 in the Interactive Cardiovascular and Thoracic Surgery Journal. And the title was Colopharyngoplasty for Intractable Caustic Pharyngoesophageal Strictures in an Indigenous African Country. Adverse impact of concomitant tracheostomy on outcome. So the problem was with the tracheostomies we put in for our patients. One of them we lost post-op, immediate post-op, and one of them at home. So the thinking was we must develop a procedure that can eliminate the use of tracheostomies when we want to do the surgery, especially those who have preserved airway. So we start, and the first case of the colon flap we did was in 2011, but I'll come back to that. So from 2006, when we started, up to now, can you go on to the next slide, please? The picture of the boy you saw there, he's the only surviving patient with tracheostomy. The rest, all of them we've lost. And so looking at our history so far, from 2006 to 2017, we've done 15 colopharyngoplasties, and then those with tracheostomy were 4. And then we did colon flap pharyngoesophageoplasty 10, and the total after 2017 was 29. Now, let me come back to the procedure that I'm presenting today. The name I use for it is colon flap augmentation pharyngoesophageoplasty. Colon flap, why? The first case I did was a 16-year-old boy who presented with the same history, unable to swallow, but had a preserved airway. When we open up, he had a diffuse stricture from the pharynx right down to the esophagus. And no, wait, don't go there yet. Let's do it. Right to the proximal esophagus. So earlier we could just have done the usual colopharyngoplasty, just put the colon at the proximal end, just suprahyoid, and then but then I realized that we could augment the opening right from the pharynx down to the esophagus using a colon. So I open everything wide and then open the corresponding length of the colon. And when I opened the colon, I saw that the end of the colon was flat. And that's how come I use the word flap. The end of the colon was like a flap. And then what we're going to do was to augment what was strictured or what was stenosed from the injury. So that is how come the name colon flap augmentation pharyngoesophageoplasty came about. And after that surgery, this patient was able to eat satisfactorily without aspiration within 2 weeks, which we have never seen before. And I went on to do 2 more cases, and we published that in the Pan-African Medical Journal in 2016 or so. So the detail of that surgery, how we did it, I think when you get into that journal, you can read it. Next slide, please. So colon flap augmentation, we open the pharynx wide. We open up to the back of the tongue where you can have enough space. And then we use the colon to augment everything from there, on both sides. But after you have done your incision, you have to measure the length you have and then measure the corresponding length of the colon before you start your anastomosis. And at the end of the day, next slide, please. That is what you have. The colon lines augment the stenosis. So you could, next slide, please. You could see that after we have done that, most of our patients, for the 10 patients, the 8-year-old boy presented with something. For him alone, at the time, was unable to solve after 2 months. So we're worried what was happening. So what we did was to examine him under anesthesia. And I remember when I looked through the pharynx right down, I was so excited about what I saw, because what we did actually made the whole place roomy, and we augmented and then I was not expecting him not to be able to swallow. And so we just not abandoned, but then we just stopped what we were doing and allowed the boy to recover. But surprisingly, immediately after the procedure, without doing anything, these boys started eating everything without any intervention. He started, so we were not able to explain why he was not able to swallow up to now. And then the second boy, oh, please go back. I'm still on the result. Yes, the second boy, 2-year-old, that is actually what gave me the confidence that this procedure is a very credible procedure. Now, this 2-year-old boy came with a permanent tracheostomy, and we opened up, did the same thing. But during surgery, I saw that there was a pinhole opening at the glottis, the supraglottic level. So I used the back of the scalpel to open up there, and it's just opened very, very, very easily. Initially I was a bit afraid, but I knew that the tracheostomy was there to protect the airway. So we did our surgery as we always do, and then this boy was sent to the ward the second day, and the night of that day, I think the tracheostomy tube got dislodged, but they didn't know. The boy was breathing normally. On ward rounds in the morning, we saw that the tracheostomy tube was out, but the boy was breathing normally. I'm sure if we had not done that procedure, we would have lost him, maybe. But that was what happened. So we quickly sent him to the ENT to examine and to advise us on what to do. And the next slide, please. No, I think there was a picture. Yes. Oh, this is not very clear. This is supposed to be there was a video clip, so we took a screenshot of the yeah. So what you see here. So it was nicely open, and they were satisfied with what they saw. So we did not put back the tracheostomy tube. And this boy, from then on, was able to swallow saliva. But you know, children immediately they see food they want to eat. But he was aspirating. But within 6 weeks, this boy was able to eat without aspiration. And that is something that we were so excited about. Now, what were the complications? All our patients, we didn't have any anastomotic leakage. There was no dysphagia they were all swallowing well. They could eat anything. If the mothers bring their children, if they come, you ask them, what can they eat? They said they eat everything. And we don't have any problem with that. We had to operate on one of them because of retrosternal adhesions that obstructed the colon. And we did a partial stenotomy and relieved that. And there was one case, a 3-year-old boy who was also regurgitating at night. And we have to just advise the mother what to do, not to feed a child very late. So those were the problems we had, and most of them are doing well. So what are my recommendations and conclusions here? I would say that this procedure is a promising procedure for severe pharyngoesophageal injuries with some lumen in the pharynx. It creates an augmented new hypopharynx, and anatomically, the colon graft is positioned along the length of the hypopharynx and the proximal esophagus, if it has some lumen in it. The procedure reduces or eliminates the need for tracheostomy before procedure is in the 10 cases we have presented. So there was no need to put in a tracheostomy before the procedure, as advised by the World WHO. And the fear of laryngeal edema postoperatively, we advised by the anesthetist to ventilate these patients 24 hours because we play a lot around the larynx. So after 24 hours, then they extubate the patient and to prevent any problem with respiration postoperatively. Limitations, our numbers are small, so we cannot draw very strong conclusions from that. The outcomes are very exciting, and hope we just hope that others will replicate the same elsewhere so that we can have more credibility with this procedure. I would like to, these are my references. I would like to thank Prof. Fripo Boateng here because he has been our trainer. He has been one who encourages us and helps us to achieve what we have achieved today. My colleague surgeons and anesthetists have been very helpful. They are excited. Now, even though I'm a cardiothoracic surgeon, but they call me esophagus doctor. The ICU nurses and the ward nurses have been very fantastic. They are very supportive when it comes to these patients. So thank you very much for listening, and thank you, Prof.
Merci, professeur Tété, pour votre présentation. Est-ce qu'il y a des questions dans la salle? Have you questions?
Thank you. Prof. Tete, I want to commend you for a very exciting and innovative approach to dealing with these very unfortunate children, as you've described. I think it's a wonderful procedure that you've introduced, and it's really, if it's picked up, it's going to help many kids. What I want to know is that, so do you do, is a free flap transfer, is that right? Or what do you do? You take the colon, and then what do? Do you take any vessels with it and anastomose, or what do you do? I just want to understand that. It was a free transfer.
Sorry, I did not go into detail because everything is in the Pan-African Medical Journal. Yes, but let me just explain. Yeah, the colon is pedicled. We use the left all the time. We use the left. Some use right. It's pedicled on the left one. So we rotate retrosternally to the neck. So it is still vascularized. So yes, pedicled. Thank you.
Il y a d'autres questions? Oui. Professeur Tété, je voulais savoir si il retire l'ésophage ou s'il passe en rétrosternal pour faire. Est-ce qu'il retire l'ésophage malade ou bien s'il laisse l'ésophage malade, il passe en rétrosternal? Technique.
And I explain why it's not. That's two. One, the two men is already destroyed. The people that are supposed to teach it will be destroyed. Because of the extensive periesophageal fibrosis, it causes a lot of morbidity when you want to do. So we want to avoid that for our patients. Thank you.
Deuxième question, il y a une femme et 10 jeunes gens. Il y a 3 adolescents et le reste sont des enfants. Est-ce que c'est accidentel ou est-ce que c'est vraiment provoqué? Même si bon, le chirurgien, c'est vrai qu'il ne fait pas cette enquête, mais est-ce qu'il a des informations?
When you present your patients and you want to know if you have selected your patient, or you take them as a count,
Yes.
or you make a selection.
Yes. When it comes to the colon flap, there's a procedure I talked about. There should be lumen. If it's a complete stricture, you cannot use it. If there's no lumen there to augment, then you can't use it. Then you have to use the traditional colopharyngeoplasty. Okay. But we operate on every patient. We operate on all patients. But anybody who presents with lumen at the level of the hypopharynx and the proximal esophagus, we do colon flap because the results are good.
The other question is your follow-up. You have, I think, 20 patients like that, something like that, less than that. But your follow-up, what's comments or lessons? You have some comments about and about your follow-up, your duration of the follow-up, and why you have so, I don't say little, but what you don't have more patients than what you have presented?
Yeah, this one, if we talk about colon bypass or colon interposition for patients with esophageal strictures, we have a lot. But these are patients with special or more complicated injuries. Okay, the literature says that about 0.6 to 7% of those who have corrosive strictures present like this. So this is just about 10% of cases we see. What I presented within the period, just about 10% of cases we see. The rest will benefit from the usual colon bypass and all that we do. But when it comes to complex and complicated cases, that as I started from the beginning, they don't expect most of us in the low-income countries to be able to do. This is the number we have. From 2016 up to 2017, we have about 4 or 5 in addition from 2017. Now the follow-up, the first, when we discharge them 10 to 12, they go home. 2 weeks we see them. 1 month, 3 months, 6 months, then every year before we see them. Every year they come for checkup.
Okay. And you don't have any problem with that?
We don't have any. The next thing we wanted to do is to do a research to look at the quality of life of all our patients. So that will give us a picture of what we are doing. Yeah.
The other question is, why you didn't add your name at that techniques? That doesn't, is it mean that you don't want, it's not original? Somebody have done it before? I want to know exactly.
I don't think
for a surgeon, another surgeon to put your name on this technique.
Prof, thank you very much. This one, you cannot do that. I think when others have done it and they are satisfied with it, then they can add your name to it.
Il y a d'autres questions? Thank you. Mr. Wede.
Je voulais dire merci au professeur Téfé pour sa présentation. Ma question, c'est de savoir le côlon est branché sur l'estomac ou bien sur au niveau du cardiaque ou en dessous de la sténose.
I need to understand it. Prof, can you help us?
Une part est branchée au niveau du pharynx. Après, il peut bien brancher le côlon au niveau de l'estomac ou bien au niveau de l'œsophage en dessous de la sténose.
What's the is it the opportunity with the rest of the colon or is the opportunity with the stomach?
Sorry, that's why I didn't want to waste time to go into the details.
Yes.
That's why I referred you to. So you harvest the colon and you take a segment. You use a segment of the left colon, right? So we go right to the transverse and sometimes to the descending colon, because most of the time you need to take a very long left. Okay, after that you do a colocoic anastomosis. Then this one becomes free, and then you do you take the part that is on the right up. So that becomes an isoprestatic anastomosis. So the patient swallows and the food moves along the colon in the normal fashion. If you take the reverse, it's an iso, and we always do an isoprestatic anastomosis. And you do that, you take the right side up and then do a cologastric anastomosis. Okay, so the patient now eats and the food gets to the stomach right away. Yeah. Thank you.
Thank you. Thank you, Mr. Tete.
Thank you very much
for your presentation. Bon, mais il se fait tard. Nous avons eu une très belle session. Nous allons mettre fin à la session et on souhaite une bonne soirée à chacun de vous. Et on se retrouve ici demain à 9h, je pense, d'après ce qui est dans le programme. C'est 9h. 9h, d'accord. Bonne soirée à tous et à demain.
Voilà, la troisième journée donc, de la conférence doit s'ouvrir demain à 9h par les adresses. Et après, il y aura 3 communications, suivi également de l'adresse inaugurale de la photo de famille, de la pause café et de communication, suivi d'une pause